Welcome to The Explainer. We're diving straight into the heart today, literally. We're unpacking the mechanisms, the ECG patterns, and the clinical management of macroreentrant and multifocal atrial tachycardias. If you've ever stared at a rapidly tracing ECG and wondered exactly what kind of structural chaos is driving it behind the scenes, you are in the perfect place. Here is our roadmap for today. We'll start with understanding macroreentrant tachycardias, compare typical and atypical flutter, spot that classic sawtooth ECG, talk about managing atrial flutter, and finish up with multifocal atrial tachycardia. All right, Section 1, Understanding Macroreentrant Tachycardias. So to get a grip on these macro-level arrhythmias, I want you to picture a rogue electrical signal, but it's trapped on this continuous physical racetrack right inside the atrial tissue. Normally, a heartbeat washes top to bottom, then resets, right? Well, a macroreentrant tachycardia is basically a massive short circuit. It's a large anatomic loop, and it usually anchors around areas of scar tissue where the electrical conduction just kind of slows down. It slows down just enough to let this reentrant cycle perpetuate. The signal literally just keeps chasing its own tail round and round. Moving right along to Section 2, Typical versus Atypical Flutter. Now, not all of these internal racetracks are built the same way. Check out this brilliantly illustrated 3D map of typical right atrial flutter. You can see those blue arrows tracing a very specific counterclockwise circuit right around the tricuspid valve. It's boxed in by the valve in the front and structures like the inferior vena cava in the back. So what you get is a highly organized, completely predictable electrical circuit. Here's the real differentiator, the crucial point. Does the circuit rely on a specific anatomical bottleneck, known as the cavo-tricuspid isthmus? If it does, that's your typical flutter. The electricity actually has to squeeze through this narrow corridor of tissue between the inferior vena cava and the tricuspid valve. But atypical flutters, totally different story. They do not depend on this isthmus. Instead, they're usually entirely different circuits orbiting around other atrial scars. We're talking scars from things like previous heart surgeries or maybe extensive ablation procedures in the left atrium. This diagram does a great job of mapping it out. It shows how physical barriers, whether that's natural anatomy or man-made surgical incisions, actually create the boundaries for these different reentrant tracks. Down in the bottom left, you see the typical flutter circuit using that natural isthmus. But the others, those are complex, scar-mediated loops. The underlying principle is exactly the same, a trapped electrical wave, but the physical geography of it changes entirely. Okay, Section 3, Spotting the Sawtooth ECG. Let's pivot to the clinical side of things. How does this built-in electrical loop actually show up on a standard piece of ECG paper? Well, you're going to want to visually anchor this classic sawtooth pattern into your brain. Because this circuit is so perfectly organized and consistent, the atria fire at incredibly fast, steady rates. We're talking anywhere from 240 to 300 beats per minute. Now, luckily for us, the AV node acts like a gatekeeper. It usually blocks every other beat, which gives us a 2-to-1 AV block and a resulting ventricular heart rate of about 140 to 150. If you look closely at the ECG, that counterclockwise typical flutter creates these very definitive negative deflections in the inferior leads. That's 2, 3, and AVF, along with positive waves in lead V1. But here's a practical question. What happens if the ventricular rate is moving so fast that those QRS complexes and T waves are just completely burying your flutter waves? You can't see them. Well, that's when you use maneuvers or push medications like adenosine or beta blockers to temporarily increase the AV nodal block. By slowing down that ventricular response for just a moment, it's like pulling back the curtain. Suddenly, you reveal those hidden, continuous sawtooth waves just marching right along the baseline. Which brings us to Section 4, Managing Atrial Flutter. What's really fascinating here is how we can take highly complex clinical guidelines and boil them down into a simple, logical recipe. Whenever you're approaching an atrial arrhythmia like this, you want to follow a strict 3-step logic. Step 1. Prevent strokes. Just like an AFib, a flailing atrium can cause blood to pool, so we figure out if they need blood thinners using the CHS2-DS2-VASC score. Step 2. Rein in the heart rate with AV nodal blockers to get the patient hemodynamically stable. And finally, Step 3. Restore normal sinus rhythm. And that third step brings us to a really unique challenge when dealing with atrial flutter. Here is an absolute must-remember clinical pearl. Getting the heart rate down with medications alone can be incredibly stubborn in flutter patients, way more stubborn than an atrial fibrillation. You can push those AV nodal blocking agents, and the heart rate just will not budge the way you want it to. Because rate control is notoriously difficult to achieve here, it heavily and quickly pushes us toward definitive rhythm control strategies. And that leads us right to catheter ablation. This is universally recognized as the absolute first-line therapy for typical flutter. Look at these mapping images. Because we know exactly where that cavalotricuspid isthmus bottleneck is located, an electrophysiologist can go in there and essentially burn a permanent roadblock right across it using radiofrequency energy. Boom, by transecting the track, you permanently break the circuit. It boasts a greater than 95% success rate with a remarkably low risk of complications. A real game changer.
Finally, Section 5, Multifocal Atrial Tachycardia.
For our final clinical pivot today, we're shifting away from those highly organized macro loops of flutter to a rhythm that is, well, fundamentally chaotic. Multifocal atrial tachycardia, or MAT. The big thing to remember here is the rule of threes. To accurately diagnose MAT on an ECG, you absolutely must identify at least 3 distinctly shaped P waves. These represent multiple, irritated ectopic spots scattered all over the atrial tissue, just taking turns firing off signals. The rate usually sits between 100 to 150 beats per minute. And crucially, this is key, unlike AFib, you will see clear, flat isoelectric lines right between these chaotic P waves. So contrast this with what we just talked about. Unlike the single, beautifully structured racetrack of typical flutter, MAT has no single circuit. It's driven by what we call triggered automaticity. You've got multiple, totally separate focal points in the atrial tissue sparking chaotically, basically competing to drive the heartbeat. It's totally disorganized, highly irregular, and the underlying trigger is just fundamentally different. Clinically speaking, MAT is a massive red flag for underlying lung issues. You're almost always going to spot this multifocal chaos in patients who are suffering from severe chronic pulmonary disease, usually right in the middle of an acute respiratory flare-up or a bout of hypoxia. Because of this, treating the heart rhythm actually means you have to treat the underlying pulmonary insufficiency first. And again, a quick reminder, do not confuse this with atrial fibrillation. Look closely for those distinct P waves and those clear isoelectric intervals separating them. Wow, we have covered a tremendous amount of ground today, navigating from the organized racetracks of flutter to the chaotic sparks of MAT. To wrap up this explainer, I want to leave you with a provocative thought to chew on. As our atria naturally accumulate scar tissue over a lifetime, whether that's from natural aging, disease, or prior medical procedures, how will that physical alteration change our lifelong approach to managing these deeply intertwined arrhythmias? The physical geography of the heart is constantly evolving, which means our strategies to keep the rhythm must evolve with it. Thanks for joining this explainer today. I'll catch you next time.